Our next speaker is going to be Dr. Martin Charns. He is Director of the Center for Organization Leadership and Management Research, Veterans Administration Health Services Research and Development Center of Excellence. He is Professor of Health Policy and Management and Director of the Program on Healthcare Organization Studies at Boston University School of Public Health. He has several years of experience in the field of organization and management research in healthcare and as an educator to health professionals. And he's a graduate of Harvard Business School, where he received both his master's and doctorate in organization, specializing in organizational behavior and large-scale organizational change. Mark?
Thank you. You gave away the secret as to what DBA means. Everybody asks me, what's a DBA? Right? It's a Doctor of Business Administration. Right? Probably there's not another one in the room, right? At any rate, well, we need some lightness for after lunch. So first off, I want to acknowledge my co-authors here. You can see their names on the list, and especially just to give recognition to Mary Foster, without whom this paper would not be a paper. So she really carried the ball, way beyond one of several co-authors in this effort. So the context of the work is, we have the call to action here around multi-level research and interventions, talking about the requirement for multi-level theory, design, and measures, and that the measurement and analytical approach should flow from the intervention objectives and the theoretical model. Now, we know there are shortcomings in practice in terms of what I just said, based upon other discussion already at this conference. What we wish to achieve with this paper is to provide some practical guidance on measurement issues in multi-level intervention research to advance the state of the science in this area, identify gaps in the literature, and that's largely around measures and interventions per se, and make some recommendations around how to close or address those gaps. So, of course, we started with the ecological model as the basis of our work, and it's one dimension of a categorization scheme that we used in a large literature review, which is what I'm going to be reporting on. Conceptually, one of the things that I think in the conference so far we have mentioned, but I would like to give greater emphasis to, is that we have both intervention targets and we have levels or units of measure. And they're not necessarily the same. And you'll see that as I present some of the data from our review. So just graphically in this particular PowerPoint, you see at the top intervention targets, and we have simply listed 4 to not overly clutter the slide, but you could think about targets at the individual group, organization, and extra or inter-organizational level that are intervening on processes or outcomes or context and also states. And then we have measures. And we may be measuring at any or all of those things, again, at the different levels. So we talk about intervention targets and units of measure, just for the terminology we started to use in this work. Now, this slide's a bit complex, and I'll spend more time on it than anything else in terms of time in this brief presentation, just to give you an example of the possible combinations of single and multi-level interventions, which you see as the rows, and single and multi-level measures that you see as the columns. So starting with the simplest case in the northwest quadrant of the table, you see interventions, we're saying, at the patient level. For example, a patient reminder implemented in a single practice setting. And we can measure at a single level. We can have dependent variables, such as patient screening adherence, and independent variables that we're measuring, such as at the patient level, such as demographics and attitudes and behaviors. So what is important to point out for this particular quadrant is the intervention is at a single level. It happens to be at the patient level, and all the measures are also at the single level. Let me progress now to the northeast, progressing east, to the upper right-hand quadrant, where you now see a single level intervention. It's that same patient reminder, but we have multi-level measures. So we have dependent variables, again, the patient screening adherence, but other independent measures. So the patient level, and then some practice level measures. So we've moved to a second level, looking at various other factors at the practice level. Now, you may be a little uncomfortable because I just described 2 levels, and I said it's multi-level. I'll tell you why we did that in about 3 slides. Looking down then on the bottom row, you see multi-level interventions. At the patient level, the reminder. At the provider level, education to providers. And at the practice level, a system, a clinical reminder built in, let's say, to the EMR. Measures, again, can be at the single level. And in this example, it's the patient screening adherence and patient demographics. And then going to the final quadrant where we have the multi-multi, you see what we have is everything I've described before, but intervention at 2 levels and measures at 2 levels. So I think it's important that we be cognizant of the fact that even though you may have multi-level interventions, you still may wind up with single-level measures and vice versa. So we have to keep that in mind. What we did was a literature review. The whole search strategy will be in the written paper, but we identified 1,781 articles, subtracted 137 that were duplicates, conference papers, letters, editorials, etc. Subtracted, giving us 1,644. I was a math major as an undergraduate. Subtracting another 449 that were primarily looking totally at biomedical effects. So we were really trying to look more at behavioral change in patients, not just the biomedical factors. And then our study is exclusively on cancer. So although we did the search expecting only to get articles on cancer, in fact, we got 164 that were not on cancer, leaving us with just over 1,000 articles related to cancer care interventions or measures or both. So then we sorted those out. And picture's worth 1,000 words. Without differentiating whether it's an intervention or a level, you see on the left side the bar graph depicting at what type of care were the single level studies. And on the right side, and you see there are very many fewer, at what level, what type of care were the multi-level studies? Okay, and so, for example, there were 60 single-level studies on risk assessment, 17 on prevention, and the 382 there is around treatment. The 329, which is the brown big bar, is on survivorship. Okay, I think that the important thing here is we're starting to classify these articles first by the type of care. Then we classified by the intervention, the intervention target. Now, I think it's important now that I tell you why we kept 2 levels as multi-level. It is because we hardly found any articles at all that covered 3 levels. In fact, we believe we identified 5. We're questioning 1. And one of the things to think about conceptually, and it's another thing as we look to advance the field, and I don't claim to have the answer, but I want to lay out the problem. Do you consider interventions that include a provider and a patient to be multi-level? Or do you, two, all right? Or do you consider them two different targets, but they're both at the same, therefore it's a single level study? I think we should have debate on that. What we actually did was count those that were two level as multi-level, and we counted those that were patient and provider as two levels for this classification. Again, we would have wound up with more single-level studies and fewer multi-level studies had we not defined our categories the way we did. So you see on the multi-level side where there were, and this is looking at intervention target, that most of them, the 28 of them are around the multi-level are around patient, and the 256 of the single level, which is the dominating bar in the whole slide, are around patient. When you divide the studies up, not by intervention, but by unit of measure, you see this distribution. Okay, so the previous slide was the intervention. This slide is based upon categorizing by the measures. Again, the largest numbers are around single level, and again, the single level studies, the largest number is around patients, and the single level studies are about 3 to 1 to the multi-level studies, and that is with our broadest definition. So to recap, of the articles we reviewed, further than a quarter of them were multi-level. They tended to be, they included intervention studies, some essays, review articles, models, qualitative measures were included in there. Of the 356 intervention studies we reviewed, fewer than a fifth of them were multi-level. The most common multi-level study was whether you're looking at the intervention target or you're looking at the measure or unit of analysis, looked at patient and caregiver. In the small print there in parentheses, we're also noting, you sure you want to count that as multi-level? And the other thing that we discovered in doing this literature review, just to raise as we're looking at this kind of work, is what do you do if there are multiple components of interventions, but they're at the same target? So those, we counted as single target or single intervention. So discussion, you ready to pull me off? I'm okay. One more slide. So things to think about in the discussion. One, more multi-level model investigation is needed. The structured literature review, we think, is an important tool. Before we went further in trying to make any recommendations, we thought it important to see what the territory looks like, and this gives us one picture of that. We need to focus on existing measures and gaps to be filled in further research. Focus on multi-level investigation offers opportunities to extend the levels that are considered. And as others have said today, we want to highlight the importance of a detailed and well-developed theory as a basis for careful analysis. And as we're doing that, to look at interventions and measures and how they might interact across levels. And that really gets us to Brian Weiner's comment, about sequential or reciprocal interdependencies. So how do we understand these interactions, at least at a conceptual basis, to guide our measurement? In healthcare systems, particular organizational measures may be especially important in effectiveness, implementation, and sustainability. Another word we need to talk about, sustainability. Those may be leadership. Certainly my own work around organizational change, and that is probably one of the largest things in the organizational literature, is the importance of leadership to change. Culture, quality, and non-financial incentives are important examples to look at, and the issue of looking at the interactions across levels, as I just mentioned. We're also suggesting looking at team-level models, cross-level models, and homologous multi-level models, where you're looking at how things are manifest at more than one level, but the same kind of thing at more than one level. So, for example, interventions at the team and both provider and team level. Questions for discussion: what are the barriers to developing both the interventions and the measures? Well, one of the things that I struggle with as I try to design this: can multi-level models be used in the context of RCTs? True multi-level models, now think about 3 levels, to address measurement issues. Can multi-level models be used with research designs other than RCTs? I know Brian will say yes. What theoretical or conceptual frameworks are helpful for conceptualizing multi-level research and developing appropriate measures? And what models address sustainability? Because it really is not going to do us a lot of good to put all this effort and money into getting change and then having that change slide back to the basic state we started with. Thank you.
Very much, Marty.